Thank you for the kind introduction. I'm so excited to be here to discuss updates in myositis therapeutics. My name is Dr. Jisun Paik, and I'm an Associate Professor of Medicine in the Division of Rheumatology at the Johns Hopkins University School of Medicine. And I'm also the co-director and director of clinical trials at our Hopkins Myositis Center. So thank you deeply for this invitation. And without further ado, I will be discussing the promising area of myositis therapeutics. So these are my disclosures today and our obligatory copyright material slide. So the outline of my talk is to give you a brief overview of the diagnosis and different major subgroups of myositis, just briefly, about 1 or 2 slides. And then I'll go into the current treatment algorithm of myositis. And then I will finish off with the promising treatments in myositis, highlighting the areas in particular in dermatomyositis, and also in anti-synthetase and inclusion body myositis as well. So first and foremost, the diagnosis of myositis, I say, takes about 6 diagnostic tools that are at our fingertips. First is the pattern of weakness, of course, because for myositis, patients will typically have proximal muscle weakness in polymyositis and dermatomyositis. But of course, don't forget that inclusion body myositis, or IBM, patients will also get proximal and distal weakness. And then we also use the muscle enzymes, the CK or creatinine kinase and aldolase levels. Third, we use the EMG and nerve conduction studies. And really, that's very helpful to tell us if someone has muscle weakness, is it truly an intrinsic muscle problem or is it a nerve problem because the nerve is not properly communicating to the muscle? Is it a nerve problem that's resulting in muscle weakness like ALS or Lou Gehrig's disease? Next is muscle MRI. This will tell us activity and also chronicity, so damage if the patient has had, myositis for some long time. And the T2 stir images are the sequence that we want to look at to look for muscle edema. And you can see here that there is evidence of muscle inflammation in the anterior and posterior compartments, and also evidence of fasciitis. And if this MRI image is not as clear, I just want to clarify that, in terms of orienting ourselves, on the top is the skin, and then right below is the subcutaneous fat, but they white out the fat, so you can actually look for muscle edema. And then there's fascia right here on top, overlaying the muscle, and then you have the muscle right underneath the fascia. So in this sequence, we're really trying to look for edema, a fluid signal, which would be very bright to tell us that someone has myositis. But remember, I always tell this to my fellows, and anytime there's a conundrum of is this diagnosis myositis or not, the key thing is that the key message about the muscle MRI is that it cannot diagnose myositis. Myositis is still obviously a clinical diagnosis, because someone can also have muscle edema because they just have a lumbar radiculopathy. And you'll see that muscle group in the posterior group of the muscles light up because of that. Anyway, I may have spent a little bit too much time, but it's just a reminder that while we have these advanced techniques, it can be extremely helpful, certainly, but it's not the be-all and end-all to make a diagnosis of myositis. And then here we have muscle biopsy, obviously still the gold standard, but I would have to say that we're not doing as much muscle biopsies as before. And the reason for that is that we have up here, right here in the middle, I hope you can see my arrow, the myositis autoantibodies. And as you know, the myositis autoantibodies can be very predictive of a patient's phenotype and can help with diagnosis and also prognosis. And that's why, in particular, in patients with dermatomyositis, we may really not need to get at all a muscle biopsy because it's very clear that a patient has it. Now, I always say that a muscle or myositis talk is incomplete without a slide on myositis autoantibodies. And the reason is that patients with myositis autoantibodies have a tightly linked correlation with the presence of a specific myositis autoantibody and the presence of specific clinical features in a patient with myositis. So if someone, as you know, has MDA5 dermatomyositis, we know that this patient will have those kissing papules or the palmar papules on the hands, and you can make that diagnosis by just looking at their hands. And we know that we're going to be able to predict that they have a high risk for developing interstitial lung disease, and this is why these autoantibodies are helpful. Now, I think the biggest concern about myositis autoantibody is where and what type of autoantibody assays are being conducted. And this is a big discussion among, myositis investigators that, if the assay is done in an improper place, this can really, or done on a poor assay, let's say, not improper place, a poor assay, it will not be very helpful, and it can make patients get very nervous, because I've had patients come to us and say, well, I had this, IBM antibody positive in the blood, the NT5C1A, and I was told I have inclusion body myositis. But we all know that the NT5C1A antibody is not 99% specific for the disease. We know that it is not. We know that certain patients with lupus or even Sjogren's can have this autoantibody be positive, and even some dermatomyositis. And we've looked at that in our cohort by collaborating with the Lupus Center and also the Sjogren's Center at Hopkins. So it's important that these autoantibodies are definitely helpful, but definitely still need the clinical context or a gold standard, especially in the cases of questionable inclusion body myositis, a muscle biopsy. And I think, the audience here certainly knows about the immune-mediated necrotizing myopathy. SRP and HMGCR are the most common, and TIF1 gamma and NXP2 are most commonly associated with malignancy. I would have to say for the past, 5 to 10 years, TIF1 gamma is more highly linked with a increased risk of cancer now. And overlap myositis is truly at the intersection of myositis and another connective tissue disease, where you either may have scleroderma or lupus, and these patients can be very difficult to manage because they have two connective tissue disease going on at the same time. And so we have to look for different manifestations, extramuscular manifestations like Raynaud's and interstitial lung disease that can be challenging to treat. All right, so that's the background of the myositis autoantibodies. So the four main subgroups of myositis to this day, although I think in the next couple of years, this will really be changed. So my talk would change as well. But the four main groups are dermatomyositis, immune-mediated necrotizing myopathy, polymyositis, but truly it's a diagnosis of exclusion, and then inclusion body myositis. But then you'll ask me, well, then why is the ACR-EULAR criteria classification criteria from 2017 have dermatomyositis and polymyositis, right? And even for clinical trials, we still say we're recruiting for DM and PM, or dermatomyositis and polymyositis. We don't specifically say we're recruiting just for immune-mediated necrotizing myopathy. So I think this will evolve, because we know that most of the patients were previously diagnosed as polymyositis using the old 1970s Bowen and Peter criteria. Most of those patients are really actually immune-mediated necrotizing myopathy, or misdiagnosed and actually end up having inclusion body myositis. Because you remember those Bowen and Peter criteria was vastly sensitive to pick up on the diagnosis of myositis, but not very specific. And so remember, polymyositis is truly a diagnosis of exclusion here in red. And if a patient has polymyositis without an autoantibody, then you really want to pursue the muscle biopsy. Because if they don't have a autoantibody, it'd be very suspicious. Maybe this patient actually has adult onset muscular dystrophy, which I've diagnosed as well. So certainly you don't want to miss those things, different alternative diagnoses. All right, so now let's switch gears and talk about the treatment paradigm of myositis. Now, this is fraught really with a lot of uncontrolled trials and case series back in the 90s and early 2000s. But I would have to say this is really the standard of care in the United States currently. And of course, I would love to learn about how it is done in Pakistan as well. So initially, we always use glucocorticoids, 0.5 mg per kg per day to 1 mg per kg per day. And if someone is extremely sick, we'll admit them to the hospital, especially if they have diaphragmatic weaknesses or severe weakness and dysphagia, they'll be getting pulse dose steroids naturally. But in the outpatient setting, depending on the severity of manifestations, we would give them steroids, plus one of these three agents. And it's really largely dependent on whether the patient has more prominent muscle plus joint involvement. So then we would choose more methotrexate. If someone has lung plus muscle, then we would either be using azathioprine or mycophenolate. Now, there's no really prospective head-to-head clinical trials looking at any of these three agents. But we do know that in a retrospective study that we did at Johns Hopkins, a pulmonologist working with Dr. Danoff, our colleague in the ILD Center, the director of the ILD Center, looked back and looked to see if there's a change in FVC or forced vital capacity on PFTs. And if it was different across the follow-up period when you compare azathioprine versus mycophenolate. And there really was no big difference. Now, this was not a prospective clinical trial, but it gave us insight that whether the patient can tolerate azathioprine or mycophenolate is probably about the same. Now, in terms of skin disease, I think it's a little bit different. This is more anecdotal, and there's some small case reports. And this is my own anecdote that I do think mycophenolate tends to work a little bit better for the skin disease of dermatomyositis. But both really work well for the lungs. Now, what about combination therapy? So yes, we start with the steroids and we use these in the we use these agents at the same. We start them off at the same time with the goal of maxing out the methotrexate, azathioprine, or mycophenolate while we're tapering the glucocorticoids. And usually the methotrexate we start, from usually around 15 to 25 is max per week. Azathioprine, 1.5 to 2.5 mg per kg per day, and the mycophenolate, the minimum efficacious dose we think, extrapolated from other studies really is about at least 2,000 milligrams per day and maxing it out to 3,000 milligrams per day. Now, one note, yes, about the combination therapy. So there is an old study in the NIH by Dr. Paul Plotz, a giant in myositis, where you could actually combine the methotrexate with the azathioprine and get some significant control of the patient's myositis and muscle strength and improvement in CK. So if you have somebody who's on methotrexate, but you can't fully control their disease and their CK is not coming down and they're still weak, but you can't quickly access the infusion medications, or insurance is giving you a hard time, like we have issues as well. I'm sure you do as well. Then, adding a little bit of azathioprine, about 25 to 50 milligrams per day with the weekly methotrexate can certainly be helpful. Now, if after about 3 to 4 months of these oral agents, then we're going to be adding one of these agents, usually IVIG, especially if they have dysphagia, and or rituximab. And rituximab, unfortunately, as you know, the rituximab and myositis trial, that was unfortunately, the RIM trial, unfortunately, was a negative study. But as you know, there were a lot of issues with the clinical trial design. The endpoint was actually time to improvement, and that not actually the percentage of how many people met the definition of improvement of a validated myositis response kind of criteria at the time. So this was a big disappointment. To date, it is still the largest myositis clinical trial, but now in the US, because it was a negative study, it was very difficult for us to get this drug approved. And this is very challenging for us to get this approved for our patients with myositis. Now, IVIG, I'm sure you've seen in the news and also in the New England Journal, led by Dr. Rohit Agrawal at the University of Pittsburgh and other investigators from Octapharma. It was a study, it was a phase 3 double-blind parallel group randomized placebo-controlled trial, or ProDerm, Progress in Dermatomyositis Study. And this included 95 patients, and it was a multi-center clinical trial. And the endpoint was actually at 16 weeks. Now, let's take a step back. We already knew that IVIG worked brilliantly in the treatment of dermatomyositis. And this was done by Dr. Delakis in 1993, and it was also published in the New England Journal. Now, it was a smaller study, but we knew that it worked as quick as 2 months, even back in 1993, and the peak efficacy between 4 and 6 months. So this is why they chose their endpoint at 16 weeks. And in this case, they also allowed concomitant therapy up to 2 immunosuppressive agents and steroids, meaning that you could have actually had a chronic myositis patient who had some weakness because you required at least mild muscle involvement, 4 out of 5, or less than 142 on the MMT-8, and without any elevated muscle enzymes, and they could enter the study. Now, what do we see in this graph? The big take-home point here is that in patients who received IVIG, these patients had a significantly higher mean total improvement score, which is the validated ACR-ULAR criteria for myositis response criteria as measured by the total improvement score that was that was validated in 2016. And the blue is the placebo group, and you can see it was much lower. Now you're going to say, well, it's not 0, which is interesting because now this did shed some light that the placebo group response was actually a little bit higher than we would expect. So actually 20 means that there's a little minimum improvement, even in patients who got placebo. But as you can see, they're definitely increased up to moderate improvement and plateaued out, similar to the group that got IVIG. So based on this led to the FDA approval of IVIG in the United States before it was not FDA approved as of July 2021. And just to highlight again, that I think it's the really old school thinking about dermatomyositis, and you need to have an elevated CK. It's very well understood and published that patients with dermatomyositis can have mild elevations in their muscle enzymes, but still be predominantly weak. They can also have significant fasciitis as well. And so this highlights the patients that they recruited had improvement despite a normal CK. And maybe their CK was not that high because they were on up to 2 background immunosuppressants. But you can see here that compared to the treatment group versus the placebo group, the MMT-8 score, which is a manual muscle testing score of 8 muscle groups, that this is pretty low, and it's comparable to the placebo and IVIG group. And this is really highlights that these patients with dermatomyositis, they really don't need to have significant elevations of their muscle enzymes. So there is the muscle enzyme here is 141 and 113 for you to consider if they're not responding, as long as they have some weakness, for you to consider to actually add IVIG. All right, so I talked a lot about IVIG, and I hope it's readily available in Pakistan as well. We have been using it for some time, and now it's FDA approved, so we're using it a lot more, and which is great for the patients as well. So what are some other promising treatments in dermatomyositis? And we've had really, truly an explosion of clinical trials. So I'm very excited to tell you about the different ones that are currently ongoing. But I would have to take you back to kind of the more mechanistic pathways of dermatomyositis. So in dermatomyositis, I would say in the past 10 years, there's been a lot more understanding because of advanced transcriptomics and RNA sequencing of tissues that we know that the interferon pathway is a primary driver of disease in dermatomyositis, similar to lupus. And the thought is that these plasma dendritic cells are secreting type 1 interferons alpha and beta, binding to the interferon receptors, and then activate the JAK-STAT pathway. And then you get the production of other cytokines through the translation and modifications of these proteins. So you get these inflammation, complement deposition, autoantibodies. So knowing that, of course, it would not be surprising to try to block this pathway in different ways. So one of those pathways I mentioned is the JAK-STAT pathway, because the interferon binds at the interferon receptor, and then the whole JAK-STAT pathway is activated intracellularly. And the first case report of a JAK inhibitor in dermatomyositis was actually a ruxolitinib back in 2014. And I remember this very distinctly because this was on Christmas Eve. I saw this come up. And this was very fascinating to me because I had also just put a patient on a JAK inhibitor at the time. And she had done very well. And I was very excited to report it as a case report. And then I saw this come out of Germany. So this was very interesting because the thought was there was a little bit of controversy when this case report came out because this patient actually had myelofibrosis and had JAK2 mutation and actually received ruxolitinib not because of their dermatomyositis, but because they were treating the myelofibrosis. But they incidentally noticed that the patient had improvement in their dermatomyositis. So there was a bit of controversy with this case report because they're saying, well, you're just treating the cancer or the myelofibrosis, and that's why the patient improved. But mechanistically, these authors came back and said, no, we know that, JAK inhibitors block interferon beta through STAT1, and it really makes sense that it could work. Now, as I told you, I was very excited when I saw that because I was so blown away by my own patient who told me that for the first time when I put her on tofacitinib, because that was what was available in the US back then, the first FDA-approved JAK inhibitor for rheumatoid arthritis. I put her on that because we knew about the mechanism of the disease, but also more importantly, she had a little bit of, synovitis. And so my patient and I decided, okay, let's try this. And within weeks, she called in tears saying, I was able to go to the beach because her dermatomyositis rash had significantly improved. And she was literally in tears. So it was a very striking moment for me that I had some almost immediate feedback from the patient that this medication was potentially working for her dermatomyositis and skin disease. Now, I think all good things happen at the same time. And, our dermatology colleagues at MGH also had noticed this and used this medication in, I think, 3 patients at the time for really skin-predominant dermatomyositis. And these patients had significant improvement. And again, all these patients on this slide actually had failed other agents. So this really led to a collaborative effort with Pfizer and me bugging them incessantly, potentially, as you might think. We need to look at dermatomyositis. I had to convince them because really at the time in 2014, they were just only excited about rheumatoid arthritis because JAK inhibitors just came on the market. But through a lot of convincing and kind of pitches or something like this, where I had to, really convince Pfizer to be like, let's please invest in dermatomyositis. So it was a collaborative clinical trial that I titled STIR, or Study of Tofacitinib in Refractory Dermatomyositis. It's a proof of concept trial of 10 patients. Everybody got the drug, and you can see here that at baseline, they had to get a skin biopsy, needle muscle biopsy, muscle MRI, and research blood. And they were given tofacitinib 11 milligrams XR daily, and at week 12 was the endpoint. Now, there was here, I wanted to mention, it was complete washout of any of their other oral agents. So it was really to assess the pure effects of a JAK inhibitor in dermatomyositis without being on anything else. So if they were on IVIG, they had to stop for at least 3 months. If they were on methotrexate or azathioprine or mycophenolate, they had to stop that for at least 3 months. If they were on rituximab, that had to be stopped for 1 year. At the time, this had just come on the market, so there was concern about the safety of any kind of overlap with rituximab and a JAK inhibitor. So anyway, and then in order to assess the pure effects, we also enforced a forced prednisone taper, and here the results show of the 10 patients that overall the composite total improvement score, again, this is the ACR-EULAR validated myositis response criteria as measured by the TIS, or the total improvement score. And you can see by 4 weeks, patients had an overall improvement with a moderate improvement sustained by 12 weeks. Now, I'm not going to say that it was everybody. There was definitely heterogeneity in the total improvement score. Some patients actually had a mild response, but then increased and plateaued out, and other patients had a really rapid response by 4 weeks. And I think a picture is worth 1,000 words. As you can see here, this patient had a very angry skin, all over her V-neck, face, heliotrope, and the shawl sign is clearly visible, and here as well. And then by week 12, this had completely resolved, and you can see here a little bit left over in the neck. And then the V-neck, you can see this patient had extensive V-neck with extension up to the neck. And this had mostly resolved by week 12. And then we had pre and post muscle MRIs, and you can see that the subQ edema and also the edema in the rectus muscle also was mild, not severe, but had completely resolved by week 12. And the same thing in the posterior compartment at week 12. Now, the beauty of this study, I think, was also really to understand the mechanisms behind and confirm the actions and the efficacy of a JAK inhibitor. So I performed the skin biopsies at baseline and week 12 on all patients. And we were able to do immunohistochemistry and stain for STAT1. So at baseline, you can see there's a significant upregulation here in the skin biopsies. And by week 12, these 2 patients in particular had downregulation of STAT1 on immunohistochemistry performed by Dr. Olivia Castillo-Rosen, where we did a collaboration to look at these skin biopsy slides that were performed. CXCL9 and 10 have been reported, especially in juvenile dermatomyositis, to correlate with disease activity. And these are downstream chemokines from the JAK-STAT pathway. And so we had hypothesized that these would also decrease with treatment because we're blocking the JAK-STAT pathway. And we only had 10 patients, so you can see there's a limited number, but you can see that there was definitely a statistically significant trend of downtrend or downregulation of CXCL10 and also CXCL9 here. Some of the exploratory endpoints, I think one question is, well, if you're blocking that pathway and, I talked a little bit about the autoantibodies. Well, are the autoantibody titers, did they decrease with treatment because these patients actually improved? So we did actually look at the titers, but we did not see any significant downregulation or a lowering of the autoantibody titer. But we did notice that, when we enrolled the patients, we included patients who had skin and or muscle disease. And so most of our patients were with more refractory skin. And you can see 71% were moderate responders and 29% were minimal responders. So 7 out of the 10 were TIF1 gamma positive. Of course, we ensured that there was no cancer in 5 years preceding entering the clinical trial. And as I stated, we required washout of all immunosuppressants or steroid-sparing agents. If they had a flare coming into the trial because we had stopped their methotrexate, mycophenolate, IVIG, or rituximab, we did allow a stable dose of prednisone, but only 4 were at 20 milligrams of daily max at entry, and 3 out of the 4 were able to completely taper off all their steroids, which was great. A little bit more mechanistic information that we were able to obtain because to really ensure what is going on, are we really downregulating, type 1 interferons, and is it doing a good job? And so we took a deeper dive and did pathway analysis and RNA sequencing analysis on these patients. And you can see, especially in the skin of these patients, we already showed you the immunohistochemistry, the stain decreased. And also here, you can see the most highly inhibited interferons were type 1 interferons and type 2 interferons, and which was quite interesting and also confirmed what we thought. But we didn't expect that this would be almost a log-fold, 40-fold change. So this was quite striking for us to see. Similarly, when we did the needle biopsies of the thigh muscle, we noticed that the patients had downregulation on this volcano plot here in this corner. We're looking for the interferon genes or interferon-related genes here, and these are IFI6 and ISG15, MX2, IFI27. Those are the commonly interferon-related genes, and those were significantly downregulated. And this also supported our initial hypothesis that this drug would downregulate interferons in the muscle as well. And I think this is how the drug is working, not only in the skin, but also in the muscle. Now here, this is not interferon, but these are complement. But we know in dermatomyositis that, the complement pathway can be important as well. All right, so this is really just confirming what I told you before. We knew that the downregulation of type 1 interferons was to be expected in the muscle. So it was great to see that it was working in the skin, in particular, as you can see with the pictures. And in the muscle, there was improvement, although we didn't have many patients who had extreme weakness. There was improvement in the muscle MRI, and then also the interferon signature was downregulated in the muscle. So based on these findings at week 12, we wanted to see the long-term efficacy and also the safety of these patients. So we actually were able to extend the study up to week 96, and 7 out of the 10 decided to continue. And in this one patient in particular, you can see by week 96, this had all completely resolved. A little bit of this red is solely like what we call poikiloderma or damage from the skin disease. And she's still doing well on the tofacitinib currently. Another interesting observation we made, which we were not expecting at all, but we noticed that 3 out of the 10 patients had calcinosis on entry. And these patients were telling us that they felt like their calcinosis was actually improving, which was quite surprising because it was not expected. But at the end of the study, this was during the pandemic. I was like, this is really not reported very commonly. So I had a very exuberant college student who wanted to go to medical school, and I was like, here, write this case series with me. So we were able to write this up, and it was nice because we had pre and post muscle MRIs, and you can see here that this is the area of calcinosis, and by C, this was gone. And then here on the T1, you can see there's areas of calcinosis resolved. And this patient actually had extrusion of the calcinosis. And she was highly motivated and took a picture. Not as small, she's comparing it to the size of the penny, but it was extrusion and improvement in the calcinosis. Another example, was here. There was an area of calcinosis and that resolved. And this is also in T1. And this patient, incidentally, not part of the study, also had x-rays done for another reason. And this kind of bulky area had loosened up here. So when we were writing this, there were actually at the time, I think, 2 additional kind of case series and case report. And one was in a patient with JDM, or juvenile dermatomyositis, and had received tofacitinib as well. And 3 months after, you can see how much improvement there was in their calcinosis. Didn't fully resolve, but certainly there was improvement in a juvenile case. Here, there were 3 patients, I believe, who had improvement in their calcinosis. One actually was a combination methotrexate and tofacitinib, and they were able to have resolution, as you can see, in their calcium deposits here on the digital tips. And they performed a DEX scan to show that these calcium areas of calcinosis had resolved as well. All right, so now after the conclusion of our trial, there has been a lot of certainly much more all going on at the same time. I think that's a beautiful thing about medicine and advances in medical research is that, when a new drug comes on the market and there is some promise, we all want to help our patients, and that's our ultimate goal. And so during the pandemic, there was the question of, well, how many studies are there really using JAK inhibitors in the literature in dermatomyositis? So we actually undertook a systematic review with additional colleagues, and you can see there's total records of 749. The unique records screened were 313. So we looked from December 2014, which was the first case report, to August 2021. And adult DM was about 34 publications and 84 unique adult patients. This is going through our whole kind of algorithm. And if you look at the cutaneous disease versus muscle disease, the skin disease, there were 28 publications, 61 patients, and all had improvement in their skin disease. And similar to our proof of concept study, the improvement in the skin disease measured by the CDASI improved within 4 to 12 weeks of treatment. There was definitely less in the evidence for muscle disease. There were 16 patients, and 15 of the 16 had objective or patient or clinician reported improvement. So that's promising, but I think, the biggest question is, we know it works in the skin. There's no question it works in the skin, but does it really work well in the muscle? Maybe it works well if you have mild muscle, but does it work well if someone has a CK of 2000 and has dermatomyositis? I think that's the biggest question for me, because we really didn't recruit patients like that in our study. And this just came out recently in August 2023, and I think this highlights this. This is kind of a real-world rheumatology clinic in British Columbia. I think, JAK inhibitors are much easier to get in the UK or in Canada than in America. And they had about 41 patients that they had collected over the years from 2016 to 2022. And they actually included dermato, polymyositis, and amyopathic DM. And they all were refractory. And you can see that the patients, not all of them continued. There were only 19 that continued the study. And you can see here that in patients who had who did not yet receive pre-tofacitinib, right? They didn't receive it yet. Their MMT8 score was 76, and then if they were on it was 78. So there was no statistically significant difference in the muscle strength score. So they're trying to say that in this retrospective real-world clinic in Canada, that there was no significant improvement in the muscle strength. So I think this is going to be an important question to be on the lookout for. And how are we going to answer that question? I think the biggest way to do it is actually through this another clinical trial. And I'm excited to report that there's actually a phase 2 clinical trial ongoing using baricitinib called the MyoJack study in the UK, led by Dr. Hector Chinoy and also Ingrid Lumberg. And so I believe that is enrolling, and I started enrolling during the pandemic. And this is really just adding it on to one of these agents. If you're on methotrexate, mycophenolate, azathioprine, you would add baricitinib to their background immunosuppression. Now, a larger phase 3 study that is a multi-center international trial, I believe they're recruiting in Europe and also Eastern Europe and Europe and also in South America and obviously the US. And we are also a recruiting site for the phase 3 brepocitinib study, which is a JAK-TYK inhibitor that is supposed to be a more potent suppressant inhibitor of STAT1, JAK-STAT pathway in this STAT1. So this will be very interesting because they're still enrolling patients and hopefully we will have a better answer because all of these studies actually require you to have muscle involved, like muscle weakness. So we will have a better answer in the phase 3 and phase 2 study. Now, when another trial is the anti-interferon beta that's still ongoing. These are all ongoing currently. Anti-interferon beta is the phase 3 trial. It's a drug by Pfizer. And this trial is directly blocking interferon beta, excuse me. But it's an infusion drug, unlike it's not an oral drug like brepocitinib or baricitinib. So we will see what will happen, and hopefully in the next couple of years, we will have some top-line results from these studies. But currently, as I said, IVIG is approved, and while rituximab was never approved, FDA approved, we still use it a lot, and we know that the patients that respond, who are they? Those patients who don't respond to rituximab are those patients who have autoantibodies. So certainly if you have someone who's not responding and they have high titer autoantibody positive myositis, definitely want to consider rituximab. So treatment considerations in refractory dermatomyositis, because we were talking about DM first, is really, thinking about and breaking it up into, is their skin more active versus muscle versus, refractory joint, refractory lung. And I think definitely refractory, so we know IVIG works, tofacitinib works. Excuse me. There is a proof of concept study using apremilast as well that was published in the past year and a half, I believe. So that is something to consider if someone is completely failing multiple agents. And then refractory muscle, I still think, we have the wealth of data is really supportive of IVIG with the ProDerm study, combination of the first-line agents, rituximab, cyclophosphamide. And I think tofacitinib, we still need to wait for a bigger phase 2-3 study. If you have someone who has mild skin and severe muscle, like that would not be my first go-to agent, a JAK inhibitor at this time. Hopefully I could give you more data in the next couple of years. But refractory joint, you have someone who has prominent joint involvement with skin and a little bit of muscle disease, then certainly rituximab and tofacitinib is a consideration. Refractory lung, again, these are the other agents to consider for active disease as well. All right, so let's move on to the next subgroup of myositis, which is promising treatments in immune-mediated necrotizing myopathy. So just to remember, immune-mediated necrotizing myopathy, the patients get proximal muscle weakness, and the statin exposure is something we ask about, and they get very high CK levels, extremely high, usually 10,000, 15,000, 20,000, or even higher. I think the highest is like 100,000. But I've never had anybody have, renal failure because of rhabdo is really, that's not going to happen in our immune-mediated necrotizing myopathy patients. But as you can see here on muscle biopsy, you're going to have necrosis of the myofibers and a paucity of inflammatory cells. So the two common autoantibodies are SRP and HMGCR, as you can see here. But don't forget that these autoantibodies, yes, they will have, you know, an association with muscle histopathology of having significant necrosis. But there are other connective tissue diseases like systemic sclerosis and lupus, where you can have necrosis of the muscle fibers as well. So that should always be on your differential. If someone got a muscle biopsy and it's a necrotizing myopathy, but the autoantibodies are all negative, we really want to be thinking, does this patient actually have overlap scleroderma or overlap lupus? And of course, if their autoantibodies are all completely negative and your clinical judgment and acumen doesn't show any evidence of another CTD, then thinking about muscular dystrophy, like some of the common adult ones that we see in the United States that have adult onset and later onset is facioscapulohumeral dystrophy, which is FSHD. But certainly I've diagnosed younger people with a dysferlinopathy, like limb girdle muscular dystrophies, and they were treated as a necrotizing patient and received multiple immunosuppressants without any significant improvement. So don't forget about thinking about other differential diagnoses. But, you know, the really heartbreaking aspect of treating patients with immune-mediated necrotizing myopathy is that if you don't treat it early and aggressive enough, the muscle really undergoes early fatty infiltration. And as you can see here, these patients in the first couple years of disease, you're actually seeing on T1 that the muscles here in the posterior compartment has already turned into fat. Remember, you have skin on top and you have subcu fat, and then you have the fascia and the muscle. So this muscle looks very healthy. You know, we say like this is like a T-bone steak. I always tell my patients, but you know, in your steak, you don't want to have, you know, you want a well-marbleized steak. You don't want to have a lot of fat in your steak. And here, this is a good area, but this is too much fat in the back. And that's what happens in our patients with immune-mediated necrotizing myopathy. So, and in this study, it was interesting because they actually highlighted the hamstrings and the adductor magnus were the most commonly affected muscle groups and SRP-associated immune-mediated necrotizing myopathy. So I would have to say in patients with necrotizing myopathy, the muscle MRI can be very helpful, especially if they have chronic myositis and you're trying to determine if someone still has active disease. And, you know, they're saying, I'm a little bit weak, but I'm not that weak as much as I initially presented to you, but is there any still disease activity? And a muscle exam may be very difficult to assess that because they have fatty replacement, which results in fixed weakness. So the muscle MRI can tell us if there's active disease. And the reason I have this figure is, you know, on the x-axis, we have the HMGCR antibody titer. And then here we have the CK. And you can see there's a tight linear correlation with as higher you go on the titer, the CK muscle enzyme is higher. So this is really highlighting this very important association that the titer and the CK are tightly linked. And so if you do check a titer and someone has active disease and it's high, then, and they're very weak with elevated CK most likely, then it's something to consider if this patient is having a flare or do I need to treat them more aggressively for their disease. So how do we treat these patients with immune-mediated necrotizing myopathy? So back in 2018, Yves Allenbach from the Myology Institute in Paris and other colleagues, here you can see here, drafted these kind of guidelines. And these are not validated guidelines, but you know, these experts are getting together and saying, how are we going to approach patients who have necrotizing myopathy, if they're SRP or HMGCR? And you can see on initial treatment, you have patients who will obviously, if they're severe or not severe, will get IV steroids and then start at the same time. You see, you know, the time is, you know, a bit urgent here because, you know, they can get early fatty replacement. So same time or within a month, you're starting a second or third agent, you know, methotrexate or even rituximab and then IVIG. And here, you can see if there's no adequate response within 6 months with this first agent, you want to reconsider rituximab and keep giving other treatments. So for SRP, you really want to probably quickly think about rituximab if the patient is not responding within 3 months or 3 to 6 months really after methotrexate. And we do this. Now, HMG-CR, there's a wealth of data that IVIG works extremely well. And we've seen this because HMG-CR was discovered by my colleagues, Dr. Lisa Christopher Stein and Andy Mammon, and also Livia Casciela-Rosen, and so we have actually quite a number of patients in our cohort who are HMG-CR positive. And these patients really respond beautifully to IVIG. You'll see that their CK will just come down very nicely with IVIG. So that's really if your patient has severe disease and they're already on an oral agent, like methotrexate, CellCept, or methotrexate, mycophenolate, or azathioprine, they're not responding, then we go immediately and add IVIG. Now, don't forget that once you start tapering IVIG, the patient can flare, so you really want to go slowly. You don't want to just stop it like that. Now, for rituximab, we also consider using it if someone's not responding to IVIG as well. Now, how about maintenance? This is a common question we get from our colleagues. Like, what are we going to do long-term to manage these patients? So we always say about, you want them to be stable for about 2 to 3 years. And this is, also supported by this guideline here, or this, international workshop recommendations from 2018, that you would continue rituximab every 6 months and at least 2 years of well-controlled disease. And here, it says here that HMG-CR patients can require, quite a long time, many years of IVIG. So I think that's an important observation to note about IVIG and HMG-CR. Another point about IVIG, another point about immune necrotizing myopathy is that sometimes we also consider plasma exchange in these patients. And this is something to consider in someone who is very severe and refractory in their treatment response. So why plasmapheresis? So remember, I was showing you in this slide that patients can have high HMG-CR titers, and that correlates with high CK levels, and that may indicate, more active disease. So if you use plasmapheresis, you're removing the autoantibodies that are potentially, pathogenic and driving the disease, and this helps with the treatment and management of necrotizing myopathy. So about 6 patients with immune-mediated necrotizing myopathy were included in this study at our Hopkins transfusion medicine. These patients were all evaluated at our transfusion medicine, and you can see that the HMG-CR patients had a significant decline in their autoantibody titer that also associated here, pre-plasmapheresis was greater than 200, post was 33, and then here greater than 200 titer, post was negative. And these patients were the best improvers or responders, as you can see. Their CK had dropped from 1,896 to 847, so a 55% drop. And this also was a 58.7% drop. So something to seriously consider in someone who is not responding to anything else. You gave them IVIG, rituximab, and they're on methotrexate, like 3 agents or 4 agents, and they're still flaring. Then you really want to consider these necrotizing myopathy patients who are HMG-CR, SRP positive, that especially want to consider plasmapheresis. And after you give the plasmapheresis, you want to give the IVIG right after, ideally. Yeah. Okay. What about other future treatments and the pipeline? Well, now, this is not in the pipeline. This is an ongoing clinical trial of efgartigimod. And this drug actually will bind and block the FcRn portion and reduce immunoglobulins. So it's similar to IVIG in a sense, but you're not giving them immunoglobulins. You're actually blocking the FcRn portion and reducing the immunoglobulins that are contributing or maybe directly pathogenic to the muscle. This is currently enrolling at our site, and it's an injectable, and it's done every, it's a subcutaneous injection, I'm sorry. This has already been FDA approved for myasthenia gravis in the US. So they're really only enrolling patients because they're thinking that patients who have autoantibodies you want to, get rid of those autoantibodies that are potentially causing the disease. And so you're only recruiting patients who are autoantibody positive who have myositis. And one last comment about HMG-CR is that if someone flares, and now I always ask this, is because don't forget that mushrooms can also have high levels of statins in it. And if a patient is trying to lower their cholesterol while taking natural mushroom, like multiple pills or supplements, they can certainly flare the disease. And this was a case report of my colleague, Dr. Adler, where, they were diagnosed with HMG-CR-associated necrotizing myopathy, and their CK, rapidly declined with treatment, with IVIG, and then suddenly it went up. And it was not because their disease was, not responding to treatment, but actually the patient was taking mushroom supplements, and you can see the nice rise in the CK that associated with the disease as well. So definitely, once they stopped the mushroom supplements, it came down. So want to ask about that in your patients as well. I think I have like 3 more minutes left because unfortunately, I wish I had more data about inclusion body myositis. And I could tell you that we finally found a cure, and we unfortunately have not, and there's still a lot more to do in IBM. However, I can tell you at least there's some exciting trials that are ongoing. All right. So why is IBM so difficult to treat? Because certainly there have been some, multiple trials in the past looking at, IVIG, methotrexate, and these all don't work. And that was really trying to target the, inflammatory features of patients who have inclusion body myositis. And that has not worked at all. So in the past, recent years, the focus has turned into trying to block and get rid of the degenerative features that we see on muscle biopsy. So the degenerative features we see on muscle biopsy are these rimmed vacuoles, mitochondrial pathology, and protein aggregates. As you can see here, all these protein aggregates. And the thought is, well, why don't we remove those protein aggregates and see if this helps and improves patients' muscle strength with IBM. So one of them was actually arimoclomol in inclusion body myositis. And some of the initial proof of concept studies showed that patients, when they take arimoclomol, it increased the heat shock response. And that is very important in clearing all those protein aggregates and misfolded protein, because this is very commonly seen in all IBM muscle biopsies. So because of this, Dr. Machado in the UK and other colleagues, including we had a site at our Hopkins Myositis Center as well. We enrolled patients in a multi-center clinical trial to receive arimoclomol. And you can see here the treatment period, and either you got placebo or arimoclomol 400 milligrams 3 times a day. And unfortunately, as you can see here, the trial did not meet its primary or secondary efficacy endpoints. And the primary endpoint was really the IBM-FRS, which is a functional rating scale, and it wasn't the 6-minute walk test or anything like this. So this was a very big disappointment, and this paper actually just got published, I believe, like November 2023 in Lancet Rheumatology. So this was a bit of disappointment, but in any clinical trial, I think we learn a lot. And it's never a waste. It gives a lot of insight to what we can target next and how can we do things better. And I think patients also appreciate that we are trying to eventually, hopefully, get some type of treatment for our patients. So unfortunately, the arimoclomol study was a negative study, but we currently there was a lot of excitement. An ongoing trial right now, as we speak, is this some exciting data that was presented at our Global Conference of Myositis in 2022. ABC008 is a first-in-class humanized monoclonal antibody that binds to KLRG1. And the company that makes it is Abcuro. And as you can see here in patients with inclusion body myositis, the thought is that these KLRG1 positive T cells invade and destroy the muscle tissue. But in patients who don't have myositis, this is all not even present. So based on this and some promising phase 1 clinical trial results, a phase 2 trial is ongoing, and we are a recruiting site as well for this clinical trial. So there's a lot of excitement about this. This is an injectable medication. So hopefully we will hear some details in the next several years. The next agent that also has an ongoing trial, the proof of concept was a phase 2 trial done in France by Dr. Olivier Benveniste. And you can see the primary outcome was the quadriceps strength. Unfortunately, it was a negative when you look at the primary outcome, but the secondary outcomes on imaging, these patients had less fatty replacement and improved 6-minute walk test. And I think that's a win. And so there's now a phase 3 multi-center international study of sirolimus in inclusion body myositis as well. And this is we are a recruiting site for this as well. So, a lot of our IBM patients are excited to enter these clinical trials, and hopefully we'll have some more exciting data. So I think there's a lot that I talked about, and hopefully this is a nice summary slide. I was able to work with some amazing colleagues to write a recent review article that just came out in the Lancet of Rheumatology. I think it literally just came out 2 weeks ago. But it was a great international collaboration with my colleagues in the UK and Japan and Ireland. And we really try to take a deep dive into what has been going on in the past years in this vast space of myositis. And as you can see, the therapies are tremendous. We did not have this much clinical trials in our space in a very long time, never. And so, as I told you before, dermatomyositis, I think, is to me, most exciting because there are multiple clinical trials that are ongoing there. And we have multiple pathways that we're blocking. So we talked about baricitinib, tofacitinib, brepocitinib is a phase 3. There's also daxdilimab, which is actually blocking a pathway of the PDCs, or plasma dendritic cells. And I told you about interferon beta infusion. And of course, we have these CAR T cells. This is emerging as well. And we are involved in this as well in the US. And then we talked about these FcRn inhibitors. There's 2 of them. Those are 2 separate clinical trials with different pharmaceutical sponsored clinical trials. And then we know about IVIG from the PRODERM trial, but there is also a subcutaneous IgG clinical trial that is ongoing as well. And here is the complement inhibition. We were a recruiting site for this trial, but this trial has completed. And so we will see what the final results are for that. And in green here, don't forget about IBM that targets those specific T cells, the KRG1 inhibitor. So we will hopefully see what is going on in these different subgroups of myositis and the significant number of promising treatments in myositis as well. All right, these are my acknowledgements, and I think that's about it. Thank you so much for your attention.